Well, good morning and welcome to a happy Friday before your Monday holiday. Today, I just want to remind you that you do have your quiz if you haven't taken it. Um, there is no homework. Your attendance today will be the quiz, and that's how we'll just work with this at this point. Today, what I want to do is I want to talk a little bit more about ventilatory or hypercapnic respiratory failure. And in order to do this, one of the things we have to look at is chronic respiratory failure. Remember, folks who have COPD, folks who have emphysema, neuromuscular disorders live in chronic respiratory failure. And as a result of that, they have their pHs that are still within a range. Normally, the pH is not going to go higher than 7.39, and their CO2s will be elevated. Remember, too, that the compensatory mechanism for this is going to be a metabolic alkalosis. So the bicarb is going to be high and match that high CO2 at this particular point in time. What we're going to look at is little on here is your curve, or my favorite curve, as we'll call it. If you remember, if you have a left shift, you have an alkalosis, your pH is increased, your CO2 is decreased. Once you move to the right, your pH goes down, the CO2 goes up, and here's your acidotic state at this particular point. So for the folks who live in chronic respiratory failure, they have an acidotic pH and they have an acidotic CO2. The other thing to remember with this too is as you move from center to the right, you're also going to move that P50. And if you remember, P50 is where 50% of your hemes are saturated with oxygen. At center line, where your pH would be normal, P50 runs right around 27 millimeters of mercury. As we move towards the right, it's going to go up at that particular point in time. And this is where, and Therese will talk to you about this, temperature correction for the ABG comes into play, because otherwise we're going to get all our readings for temperature of 37 degrees Celsius, and we're going to look as though the patient is really at the center of the curve. One of the things about chronic respiratory failure, this is something that develops over time. And you can see on here, we talk about weeks to months, and it continues on into years. Acute respiratory failure, something that happens within the first 24 hours, maybe 48 hours, but very, very acute, okay? So, if you just happen to get sick, you're acutely sick at that particular point. But with chronic respiratory failure, this has been going on for a while. The kidneys are going to retain the bicarb. You also have to think, though, that there's only so much bicarb the body can retain. Remember, it's not a major storehouse. It has to hold on to what it needs, and that's basically what we're looking at. So I told you the pH is going to be less than 7.4. It's going to get as high as 7.39. If you're out of range, the pH is going to be happy once you hit 7.35, and it's going to work its way back up to that 7.39. It's not going to go higher than that 7.4. If you do see a patient who has chronic respiratory failure and their pH is sitting at 7.4, you've got a mixed problem going on at that particular point in time. And also as a result of the problems that we know with our patients who have COPD, neuromuscular disease, these folks are going to have polycythemia. So what causes acute on chronic respiratory failure? Well, this is something that's happened on top of a chronic condition, something very acute. As you can see, it can be bacterial, it can be viral, it could be even CHF, pulmonary edema, chest wall dysfunction, broken ribs, something else. I like to use the example, grandparents going to visit with their grandkids. Unfortunately, 2 or 3 of the grandkids have been running fever, not feeling well, throwing up, doing different things along that line. Grandparents, we still want to see the grandkids. They go visit with them. The folks come home. Granddad actually has COPD. When he gets home, he's not feeling too bad, but he's or he's not feeling too well either, but he's nothing that he's really concerned about. Next morning, his wife tries to wake him up. He can't get out of bed. He can't breathe. There's your acute condition. And that acute condition is now planted on that chronic condition. When we're dealing with these folks, how do we want to treat them? One of the things, and this is something you must remember, we're always trying to normalize the pH, okay? If you try to normalize the CO2, you're going to throw that pH out of range. If you throw your pH out of range, you're going to face things like seizures, coma, failure to wean. Just think about all the negative things that are going to happen. So when we're dealing with patients who either have COPD or neuromuscular and live with chronic respiratory failure, we need to normalize the pH. The question is, where should we have that pH? The answer is 7.35 and let it do its own thing. The other thing we're going to try to do is improve oxygenation. With these folks, remember, we're going to have to be careful how much oxygen we give them. You cannot wean a patient with COPD if the PaO2 is in 95. If you remember, up to 60, the patient has the peripheral chemoreceptors that they're using. Once they get beyond a PaO2 of 60, they start to slow down with their breathing. So if your patient has a PaO2 of 95 millimeters of mercury, we're going to have a great big issue. We need to improve airflow. We need to make sure that we're getting the gas in. We also need to make sure that we take the gas out. Treat any infections the patient may have. Also prevent any secondary infections. One of the biggest problems we had, and we still have it, not as bad as we used to, is ventilator-associated pneumonia. That shows up about 48 hours after the patient is admitted to the ICU. So what we need to do is treat whatever the underlying cause is and then prevent further problems at this particular point. Monitor, maintain a fluid balance. It is amazing when you walk into a patient's room sometimes and they're just so fluid overloaded. If you touch them, they start to weep. And it's just, the sheets are all wet. The bed is all wet as a matter of results of all of that. So we do have to watch that fluid balance. We sometimes forget, though, if you have that extra fluid on board, it is going to cause problems with the patient breathing. It is going to decrease our efforts to improve the airflow, and the other issues are going to actually get worse also. So some of the secondary complications we see with patients on ventilators, and if you remember, patients have a tendency of dying from their secondary complications more than they'll die from their primary reasons so why they went on the ventilator. Sepsis, multi-organ system failure. We saw this in emergency care when we talked about burn patients. This is one of the main reasons why those guys die. Pulmonary emboli, this is why we need the TED hoses. Make sure that we're keeping the blood moving. Remember, blood that doesn't move stagnates. When it does, especially in the deep veins, it will turn into emboli and start traveling throughout the body. Barrel trauma is another way of saying a pneumothorax. Too much pressure in the alveoli, going to cause them to rupture, unfortunately. Volume trauma is when we give you too much volume. Right now, we're controlling the tidal volumes we're giving to our patients. We're going to talk quite a bit about that. We talk about putting our patients on ventilators. One of the things, too, that we talk about is atellect trauma, and that is atelectasis caused by too small of a tidal volume, and that causes problems for our patients, too. Infections from catheters. Anytime you make an opening in the body, you're allowing a secondary infection to get into the body. One of the things that we as therapists do is we're a second set of eyes in an ICU. And if you're taking care of a patient, look and see where the catheters are. If you see any swelling, any redness, any heat, make sure you discuss this with the nurse and with the physician. There could be an infection at that particular point in time. Cardiac disorders, GI ailments, renal disturbances, all of those come from the way that we ventilate our patients. Malnutrition, we're still trying to figure out how do we want to feed these patients? Do we underfeed the patients? Do we overfeed the patients? What are the consequences of not feeding the patients? And that's something I think that's going to go on for years yet because we still haven't figured it out. ICU psychosis, some people will tell you it exists, others will tell you it doesn't. We see this with our patients, and we see this partly because people don't talk to patients. You need to talk with them. You need to tell them what you're doing. They may not understand everything, but they understand that there's somebody there talking to them. If you go in there and you just start flipping them around or sticking them with needles, they have no clue what's going on and they're going to become extremely paranoid. I have an article I'm going to share with you. It talks about people who suffered PTSD after being on ventilators and vents. And this was years later, and you still have reactions to things that go on around them. And it came from them being in the intensive care unit and on ventilators. So the question comes up, and part of the question is really, do we care? Just because you have an acute or acute on chronic hypercapnic or ventilatory respiratory failure, why do we care? What's the big deal? Well, the big deal is you're talking about different people with different problems. An acute patient, as we said, is somebody that happened to quickly. A lot of these patients are normal patients. They don't have any other secondary conditions. They can sometimes heal rather well and do extremely well and get off our vents a lot quicker than they do. The patients with acute on chronic, they have underlying conditions. And when we're taking care of them, we have to realize that these underlying conditions also have to be dealt with. And we may make sure that we do it appropriately. Otherwise, we're going to cause more problems. One of the things, we know that COVID-19 is really throwing a lot of this out of the window, and we're having to do a lot of the same things for both of these classes of patients because we're losing a lot of acute patients in the process at this particular point. So, but anyways, for the most of our patients, excuse me, how do we know my patient's an acute patient or acute on chronic patient? The simple answer is pull out their chart and read it. The long answer is we may not have that chart. So what we need to look at in this case is we're going to look at the ABG. We already know that if in order to be in respiratory failure, the PaO2 has to be less than 60 millimeters of mercury. The PaCO2 has to be greater than 50 millimeters of mercury. We have not talked about the pH, and the reason is the pH doesn't play in that initial assessment. This is where your pH is going to come into play. The other thing you always want to remember, the ABGs for these folks are always going to be an acute or uncompensated respiratory acidosis. So we're going to see these folks with those decreased pHs, elevated CO2s. And that's something to remember. The ABG is always acute or uncompensated respiratory acidosis. So let's take a quick look at ABGs. You're going to be talking about ABGs in Teresa's class. One of the things I want to tell you now, when we talk about the ABGs for our patients in our intensive care unit, we're talking about the ABGs that are going to start when they come into the hospital and when their disease process at this particular point started. Those ABGs are not necessarily even going to be close to what you have learned about ABGs. They are going to be these uncompensated acidotic ABGs, and they're going to continue on without any compensation for probably the first 24 to 48 hours. After that period of time, when the body starts to compensate, you're going to fall back into the ABGs that you've learned how to interpret in the past. And like I said, Teresa's going to talk about this, and she's going to go through all of those with you, and it works out beautifully for both of us. So looking at ABGs, if you remember the normal values, pH 7.35, 7.45. Ideal pH 7.40. PaCO2 35 to 45 millimeters of mercury. Ideal CO2 40 millimeters of mercury. I'm going to skip this PaO2 and the SaO2 at this point. Bicarb. If you remember bicarb, it's 22 to 26 millimeters of milliequivalents per liter. 24 is the ideal for that one. And then basic cess is a plus or minus 2. You could say 0 at that particular point would be in the middle. As long as it's between plus or minus 2, we're fine as far as that goes. Why did I skip the oxygenation ones? Because your pH, your PaCO2, your bicarb, your basic cess all go together. They all impact each other. When we look at this oxygen side of the house, now we're going to talk about the PaO2 and the SaO2. These two influence each other also, and they also are part of your content formulas that play into your Shunn equations too at this particular point. If you remember, we measure pH, PaCO2 and PaO2. Remember, the Sands electrode is your pH electrode, your Severn House is your PaCO2 electrode, and your Clark electrode is your PaO2. So these are all measured. Your SaO2, your bicarb, and your basic cess are all calculated from these values. Some of your ABG machines, and I mean, they've really gotten really good, but there's points and times when the values on some of these are so high or so low that they cannot calculate a particular value off of your ABG slip, okay? The other thing I want to mention about ABGs is when you're interpreting ABGs, you have to interpret both sides of the ABG. You need to interpret the acid-base balance. The acid-base balance is your pH, your PaCO2, your HCO3, and your base excess. Your oxygenation side is the other one. This is your PaO2 and your SaO2. So when you do interpretations of ABGs, you have to interpret both the acid-base balance and the oxygenation, okay? Don't forget that, because that is vitally important, because if you remember, we're treating two basic problems here, ventilation, and we're also treating oxygenation. When it comes to the ABG, this is the part that people go, very interesting. And if you notice the piece of work art here, it's called the Screamer, and it sometimes goes quite along with what we're talking about when it comes to ABGs. When we're trying to determine acute and acute on chronic, this is where we look at the pH. And the difference with the pH is how does it move, okay? In acute hypercapnic or ventilatory respiratory failure, for every decrease of 0.08 in the pH, you're going to see a CO2 increase by 10. We're going to start our math, and you're going to see it on my next home board slide. We always start our pH at 7.40. Remember, I told you that's the middle, that's the ideal. When we start to look at the PaCO2 increase, that increase is going to start at 40 millimeters of mercury. That is also the center, that is also the ideal. When we look at acute on chronic hypercapnic or ventilatory respiratory failure, the pH is going to move a little bit faster. In this case, as the pH drops by 0.03, my CO2 is still going to go up by 10. We're still going to start at a pH of 7.40. We're still going to start at a pH CO2 of 40 millimeters of mercury, okay? So the important thing to remember with this, in acute hypercapnic or ventilatory respiratory failure, your pH will decrease by 0.08. When it does, the pH CO2 is going to increase by 10 millimeters of mercury above 40. And we're going to start that pH at 7.40. In acute on chronic hypercapnic respiratory failure, that pH will decrease by 0.03, and when it does, the CO2 is going to go up by 10. Remember that 10 is going to be added onto that 40 millimeters of mercury, and we're still going to start that pH decrease at 7.40. So, summing a little bit of this up, remember the ABG is always acidotic. The pH to be acidotic has to be less than 7.35. The CO2 has to be greater than 45 millimeters of mercury. It's the ABG, specifically the pH and the PaCO2, that's going to determine if your patient is acute or acute on chronic in hypercapnic or ventilatory respiratory failure. We need this information to make sure that we're taking care of this patient appropriately. Remember, too, that when we're dealing with these patients, and this bears repeating, you always normalize the pH. Do not normalize the CO2. And there, a little bit to the side, I've written this again, the acidotic pH, PaCO2, ideal pH, 7.40, ideal PaCO2, 40 millimeters of mercury. These are the starting points we use to determine, are you acute or are you acute on chronic? Okay, so we're back. Had to take a little break there. So, as a reminder, for acute hypercapnic ventilatory respiratory failure, we're going to see that pH decrease by 0.08. We're going to see that CO2 rise by 10 millimeters of mercury. Above the base, the pH base is 7.40. The CO2 base is 40 millimeters of mercury. So just a really quick little math on my little board here. ABG shows the pH is 7.32. So we want to know, where's that PaCO2? You can say, well, just read it off the slip. We're going to say the slip doesn't print it out for some reason. Your machine's not doing as much as it should. Eventually, you're going to get that PaCO2, but you need to have a little bit more information now to see what's going on. So you can take that 7.40, take away the 7.32, you come up to 0.08, or you can just take the 7.40, subtract the 0.08, and you're back at that pH of 7.32. And we know a little bit about this patient, so we know that there's an acute, happens to be an acute patient. We only had one change of 0.08. So therefore, there's only going to be one increase of 10. So we're going to take the 40 that we have as our base, add the 10 to it that resulted from the change, and we expect to see the CO2 to be around 50 millimeters of mercury once the machine starts working again. So again, just to show you, if acute, the pH decreases by 0.08, CO2 increases by 10. The base again is pH starts at 40 in 7.40, and the CO2 is going to start at 40 millimeters of mercury. So if the pH were 7.16, where do we expect a CO2? Off to the side, we took the 7.40, subtracted the 0.08, came down to 7.32. One change. 7.32 minus 0.08. We have a second change because now we're at 7.24. 7.24 minus 0.08, we're now at 7.16 where the pH is. That's a third change. Each time that changed, remember that CO2 went up by 10. And so at this point, 3 changes, the CO2 is going to go up by 30. The base of the CO2 is going to be 740 millimeters of mercury plus 30. We expect to see that CO2 at 70 millimeters of mercury. And sometimes people go, well, what if it's 71? What if it's 68? It is close enough to that 70. It is still an acute condition, okay? If you think about it, if you're going to be doing ABGs, one of the things you'll see, sometimes your patients will start hyperventilating a little bit. So other times they may just hold their breath because they don't want the pain that goes with it, even though you're the best ABG drawer in the world and you're not going to hurt them. And so you're going to get just a little bit change sometimes on those CO2s. Other times you're going to be right on and you really don't have to worry about it. On the other side of the house with acute on chronic, remember these patients live with chronic respiratory gases, okay? We're going to use the same parameters. The pH is still going to start at 7.40 and the CO2 is going to still start at 40. The biggest change is instead of decreasing by 0.08, the pH changes are going to decrease by 0.03. CO2 will still increase by by 10 for every decrease of the 0.03. So in this case, we're going to do our pH of 7.31. We're going to go ahead and we're going to take our 7.40, subtract the 0.03. We come up with 7.37. We have one change. We're going to again subtract the 0.03. We're coming down to 7.34. We have two changes. We do a third one and we're now again at 0.03. We've hit the pH of the 7.31. That's our three changes. Three changes, our CO2's gone up by 30 again. So in this case, we're going to see the pH CO2 rather, at 70 millimeters of mercury. Okay. Question comes up, well, how do we know which one to use? And the answer is, there's little things that you pick up. Sometimes, though, it's just a matter of picking one, doing the math, and then figuring out, does your pH anywhere close to where you need to be at this point? If it is, then that's what your condition will be. So just to show you two examples here, over here you have a pH of 7.00 in the case of an acute one. And this is a shortcut, easier way of doing this sometimes. Take your pH of 7.40, subtract whatever pH you have on your ABG slip. You know your change in this case, 7.40 minus 7.0 is 0.40. I want to know if this is acute. I'm going to divide by the 0.08. And you guys know in this case, you're just going to take 8 into 40. You have 5 changes that occurred in order to get from 7.40 to 7.0. And those 5 changes are going to increase that CO2 by 50. 5 by 10 is 50. And so if I look at my CO2 should be right around 90 millimeters of mercury. If this were an acute on chronic and I wasn't sure that, that's what it was, and instead of doing the acute, I'm going to try the acute on chronic. I'm still going to take the 7.40, subtract the 7.00, come up with that same 0.40, except I'm going to divide by 0.03. 3 goes into 40 right around 13.3 times. You've had a little over 13 changes to get from 7.40 to get down to 7.0. Each of those changes, your CO2 has gone up by 10. So 13.3 times 10, your CO2 has gone up 133 times. 40 plus 133 puts your CO2 at 173. You probably won't see that. You'll probably see something else. A lot of your ABG machines cannot read up above about 120 or so. You really don't need probably that precise 173. If you're above 120, you know you have an acute on chronic patient. Okay. So fairly quickly, the Insider's Guide to ABGs for us. Whenever the pH is normal, the ABG is normal. Do not start messing with normal pHs, okay? Once you've normalized that pH, it will take care of normalizing your CO2. When you're doing ABGs, you always don't need the bicarb. If you're doing an acute or acute on chronic, that bicarb on that first, second, how many early ABGs is not tied into the ABG that you just performed. Let me repeat that. If you remember, it takes 24, 48, maybe 72 hours for a bicarb to be able to respond to elevated CO2s. The kidneys have to retain bicarb. There's only so much bicarb the kidneys can retain. And so until they either get rid of the excess or have that ability to start retaining it, that bicarb does not belong to the ABG that you're working with. Any PaCO2 greater than 120 millimeters of mercury is unreliable. You don't know where it is. We saw that the last time on that last example. The PaCO2 would have been up around 173, way high. Machines don't read that high, and as a result of that, we're not sure where they are at that particular point. In chronic respiratory failure, the pH, when compensated, will never reach 7.40. Remember I told you the top is 7.39. If you have a 7.40 with these patients, you have a mixed problem going on. You either have a respiratory acidosis, well, of course you would, a respiratory acidosis, but you're also going to have a metabolic alkalosis. And what they're doing is they're pulling and pushing at that particular point. And here's the trick to the bicarb again. It will not respond if your CO2 is greater than 85 millimeters of mercury. There is no way the bicarb will be able to change or do anything for you until that CO2 comes down to less than 85 millimeters of mercury.